Good morning. Good morning, David.
Hamed, can you hear me okay?
Yes, I do hear you okay. Actually, I like to start something that I like to discuss, have your expertise on first
Sure.
today. And that is obviously it's regarding both pain pump and stimulation device. And I think, as a surgeon, we are less versed, less experienced in that. Um, and I like to understand a little better your workflow. And if you are okay with that, I like, based on what you are going to tell me, write a small little write-up for society about what the workflow look like, that what steps do you take in the investigation of when to apply stimulation versus pain pump, the diagnostic and the steps that are required to get one or the other not only approved by the insurance, but as well, put a clinical indication for that. And obviously, yeah, unfortunately, people of your profession and people of my profession don't work close enough for really understand that it's sometimes what we do for each other is almost like a black box. Like you send the patient to us and we do five surgery and send the patient back to you after there is really all those five surgery failed. And as well on our side, there's a little misunderstanding about what your workflow is. Do you mind to
Yeah.
talk maybe 15 minutes about that?
Oh, I'd be happy to. Yeah, I think it's a really good topic, actually. So, are you ready to go right now?
Yeah, yeah. I mean, we are. It's 10:02, and if you don't, we take as much time. But if you can talk about 15 minutes about your workflow, your indications, your diagnostic, both as required by insurance and what your actual practice is. Probably there's always some difference between what insurance want and what really necessary. Yes, please go ahead.
Sure. So first of all, we work with surgeons all the time, just like you work with pain docs. And our philosophy is that if you guys can fix the problem, please do, and then we don't need to get involved at all. So
And
that's the
if you're
best
okay with
outcome.
that, I'm going to ask, clarifying question along the way.
Sure.
Now, you and I, we have been sending for what, 10 years almost now, patient to each other.
Sure.
And, um, and there is that, what you're saying that if there's something mechanically need to be fixed, that need to be fixed. And I would say probably 20% of 20 to 25% of our practice is based on that, meaning that there is a truly instability and or
Yes.
spondylolisthesis or scoliosis and so on. About probably 70 to 75% of our practice is like it's something that you see it could be a pain generator, but it's not really something that you would say it requires immediate action. And I can return the favor and say, in those majority of the cases, if you can help the patient, I shouldn't be doing surgery. So it goes both ways, but please go ahead.
Yeah, that's a really good point. And the obvious ones, if there's structural issues that are instability, then fix it. But you're right, there's a judgment. Do you want to try the surgery to see if it works and then send them to us, or do you want us to try what we do first? So my feeling is the lower level things that we do in the pain clinic, like epidurals, radiofrequency ablation, and that type of thing, those are very benign procedures. And so I always like to try those before sending somebody to a surgeon. If they work, great. But if it's, you know, a more complicated deal, failed back surgery, then, is the second, third, fourth, fifth surgery really warranted? At some point, you guys might say, hey, why don't we try what we do? And neuromodulation, we look at it like that's what we do after everything else fails most of the time. There are a
Mhm.
few diagnoses that we might want to go there earlier, but usually we want to reserve it kind of at the end of trying simple things. So we move from simple to more complicated as we need to. And the the shift in thinking is once we start thinking about implantable pain control devices, the exact diagnosis is less important. All that really matters is does that device help the patient's quality of life? So we're not trying to make a precise diagnosis anymore. We're simply putting in a system and we're saying, does it help you or not? And we trial it for a week or a day or whatever it takes. Um, so that's a different shift in thinking. The other issues with implantables is that they're very expensive. Um, they're the payer dictates what we can and can't do most of the time. And some payers like Medicare are more flexible, others are less flexible. So that we always think about that up front, who's the payer? Um, and we also think of neurostimulation as less drastic than targeted spinal drug delivery. On the other hand, we think that targeted spinal drug delivery is the go-to therapy when nothing else works. And it's much more, I would say, powerful for a myriad of diagnoses, whereas neurostim is very good for certain very selective problems, specifically neuropathic pain, especially extremity rather than axial. Um, and it works great. And complex regional pain syndrome is a good example. We think there's blood flow improvement with neurostim, with
Mhm.
electricity. Um, when we think about pain pumps, that is also a very specialized area, and many pain clinics don't manage pain pumps effectively. They do what's called microdosing, which is easy for the doctor, completely safe, but in my opinion, most of the time pretty inadequate. I mean, if you think about it, are we really going to get good pain relief with 1 milligram of morphine in 24 hours in the spinal fluid? And there's data out there that says it works, but maybe for a few select patients, there's probably a big placebo effect with it.
Yeah, yeah. But as well, something I learned from you is that narcotic is not the only thing you use. As a matter of fact, the combination, the cocktail of the things that you use make it more efficient. But coming back to that, so um, patient comes with a pain. The first thing we are going to do to find out if there is instability, meaning that something that requires surgery. If that's not the case, I think first patient is in your domain. What that means, um, conservative management, injection, various type of injection. That's another talk about what kind of injection is more helpful for what kind of situation. But coming back to that, let's say patient doesn't really require structural surgery and you have done all the low levels. Now that patient, um, there are two paths there. And the two paths, from what you just told me, I understand that stimulation is the first thing you would consider, and the pain pump is the second thing you would be considering. Is that understanding correct, or is it something that separate these two groups from the get-go?
Well, we always think STIM is more likely to work in certain cases, but we have a really low level of trying a STIM. We'll try it for all sorts of things because if it works, great. It's much less drastic. It's epidural, not intrathecal. It doesn't involve drugs. It's like a cardiac pacemaker more than a drug delivery system. So we like it because it's kind of less drastic. But on the other hand, STEM has got a bunch of problems. It's number one, the trials fail about 50% of the time. And even when the trial is successful, the patients, all happy about it. We implant, and half the time they say it doesn't work anymore. We see it, we hear that all the time.
What
So
time frame is that? Now, like when they pass the trial and then you implant the permanent one, in what time frame do you see that many of them, or what percentage fail in what time frame?
sometimes we see it right away. The trial works great. We implant and it never works very well at all from the start.
Mhm.
Other times it works well for a while, maybe 6 months, 12 months, 2 years, and then the patient goes, I don't really like it anymore. And we've reprogrammed it. And that's a ubiquitous problem with neurostim across the world, basically.
Yeah.
And a couple of issues come up. First of all, we trial and then 2 weeks later we do an implant and the spine changes in that period. So sometimes we think we can't get the leads where we want them to be, or there's scar tissue that's formed where the leads used to be, and now it's not going to be as effective.
Yeah.
So we're thinking of new techniques like put the leads in for trial,
Hmm.
bury them, and then put the device in late, the IPG later. We used to do that, but there was a higher infection rate, so we
Yeah.
stopped doing it. But we might go
Yeah,
back to that.
I used to do that. That was the first way I did stimulation.
Yeah,
I was trained by a spine surgeon, and he would just place a single lead, bury it, and then put in the battery the next week. So that's how I started doing stim.
Yeah.
yeah, we did
But
too.
now, if in your
But
both experience, what percentage would you say they fail right away? What percentage fail within the first 6 to 12 months, I would say, and what percentages you would think that the patient get a lasting effect? Just ballpark. What would you think?
can I just add something? I used to be much more conservative until I joined Dave with who I would trial stimulation for.
Hmm.
Um, and I so now I appreciate trying stim on a wider variety of people, because what I found is it's really hard to predict who is actually going to do well and who is not.
Hmm.
And if this insurance company will pay for it, oftentimes the stimulator will work for people.
Hmm.
What I think happens is that I think stimulation is very, very good for neuropathic pain. And for ongoing neuropathic pain, I think it's quite durable. I think it works
Yep.
quite well. And I do think and this is an observation of mine, and this is just how I've kind of grasped or tried to wrap my head around this. It's sometimes called tolerance to stim,
Hmm.
but I think spinal cord stimulation, especially the newer waveforms, are can actually help with what I tell patients is mechanical or nociceptive pain. However, as the spine continues to degenerate, the mechanical pain increases, and I think it just overpowers the ability of the stimulator to
I
provide
agree.
relief.
I
So
agree.
I tell them, so I try to educate patients now with the expectation that yeah, it works now, but if in the future it doesn't seem to work as well, we
Mm.
need to go back and address mechanical pain. And sometimes you from you've shown me that the sacroiliac joint can be an issue. So we go back and we can look at the sacroiliac joint for, especially for axial back pain. If that's not the main pain generator and they're still having pain, then that's when you consider surgery, and then you
Yeah.
want to do the least invasive
Yeah.
stabilization possible, which is often the OLIF, I believe.
Yeah. Well, in this, when I
Don't
was
you think
training,
do you think that's true, Dave?
Mohammed, what are you going to say?
well, I was just going to say when I went
Oh,
to training, neuropathic pain was the traditional indication for stimulation device placement. So I totally agree with you on that. And I as well see that lots of people with axial pain, they improve with the stimulation. So I think there's a
Yes,
group of people that we have been neglecting. They are a good combination. And I agree that still probably it works better for neuropathic pain than for
yes,
axial pain. But I just want to know still from your practice, considering you have a very busy stimulation practice, just ballpark, one of the things we need to talk to our patient is about statistic, right? And then nothing
mhm,
get more realistic than what you guys are already doing. So what can I tell, or what can we as surgeon tell our patient to what percentages you can expect it to work long term versus short term versus you just trial worked, you put it in, it just doesn't work at all. What would be that ballpark?
so there's some data that shows that 40%, 25% of stems are explanted within the first couple years of after they're
Okay, so
mhm.
that's
placed. 25%, that's a lot. And then
no, actually, that is we come back to that. I think that means that 75% patient sees a reason to keep it in. I think that's pretty good number. If you look at the spine surgery results and so on, that 75% is not bad at all.
it isn't. But then when the device reaches its end of battery life and the patient is going to either have it replaced or not, only 40% of people want to have it replaced. Whereas if you look at pain pumps,
Yes.
95+% will have that pump replaced. So the therapy is much more durable and much more powerful for
Got it.
all sorts of pain.
Got it. So that's actually very good and scientific kind of way of answering that.
But I'm not sure that I'm not I think in the past we didn't have as much to offer for mechanical pain. Like we didn't offer SI joint fusions, for example, for
Yeah.
that mechanical issue. And I sometimes mechanical issues, then
Mhm.
they tell me that there's I had one patient who had mechanical issue I addressed, had stimulation for neuropathic foot pain. And
Mhm.
when I went back to talk with him, the first thing he said is, "Oh, my stimulator is working better for my foot now." And I think it's because we addressed the mechanical issue and then the stimulator is working better for what's best for, which is neuropathic pain.
Yeah. Yeah. Now, what would you say in your own practice right now is that what percentage of your stimulation is for mechanical or what I would call probably axial pain versus lower extremity versus neuropathic pain? Is it half-half, or what would you say it is?
Seems like most of our patients have both axial and extremity pain.
Yes.
So
Correct. So it's a
Yeah.
combination.
yeah,
Would you try always the stimulation device before you do pain pump, or is it some people, or is the algorithm in your practice that you say the stimulation first, then pain pump, or no, we're just going to bypass it, go directly to pain pump? What would you say?
we rarely implant a pump unless they've tried a stimulator first.
Got it.
Mhm.
Got it. Makes
Now,
sense.
and I have to say, there's an economic incentive for pain clinics to trial stimulators because they're very lucrative for the pain
Mhm.
clinic. They're simple and easy and safe to
Mhm.
trial.
Hmm.
So there, some of that's going on too, in pain clinics. But I do think it's just good for the patient to try it. It's so
Got
easy.
it.
It's an epidural, basically. That's all it
Yeah.
is.
And obviously, we talked about that with stimulation device. I think we have more familiarity. It's always a trial. What, 3 days, 4 days? What would you,
A week.
a week? And
Yep.
then they try all the possible and the programming and so on. And then what percentage improvement do you usually expect before you say move on to the permanent one? What would you say?
I think officially we say 50%. I
Okay.
think that's
That's the
what,
insurance company threshold.
Yeah.
yeah, same with pumps.
Yeah, but that's actually lower than for sacroiliac joint. The sacroiliac joint injection, they
Yes.
expect 75. Insurance expects 75.
But
Now,
you see some of these patients, this is what I tell patients is I
mhm,
see some patients that when we take out the trial leads,
mhm,
they cry because they had so much relief they don't want to remove it. And then on the other end of the spectrum, there's patients who just didn't like it
yeah,
and we just
yeah,
take it out. So it's very hard. But the nice thing about the trial is you get to at least give them a test run before you implant
yeah,
something semi-permanent. So
yeah.
it's very nice to at least try.
No, but you do something similar for pain pump as well, right? You do a trial, you do some intrathecal injection. Can you run us through your algorithm and make us understand how you, okay, we have, let's say we have done the stimulation, it didn't work. Now we are going to the pain pump. What is your workflow there? How do you diagnose the proper patient for that?
Well, let me just say one thing before we move on. So we have a number of patients that have stims and pumps. We put in a stim, they do it
Yes,
for a few years, and then
Mhm.
they're worse, and then we put a pump in, and they have both devices, and they both do different things. So that
yes,
works really great for a lot of folks. But if you think about pain pumps, I started doing, labor epidurals as an anesthesiologist, and I was amazed at what bupivacaine could do to stop labor pain. And you guys, do spinal anesthesia for surgeries, so we can block pain. The problem is, people can't walk if you put bupivacaine in their spinal fluid. With pain pumps, we can put 10 to 20 milligrams of bupivacaine into the spinal fluid in a 24-hour period, and patients walk and drive and have normal strength, which always shocked me. So, in my opinion, bupivacaine is the most important medicine in that pump.
yeah,
That's what is great.
yeah. But there is a physiologic thing to that, right?
What
The
is it?
pain fibers are the thinnest and least myelinated,
Yes, C
whereas the
fibers.
motor fibers are heavily myelinated
Mhm.
and they are the most robust, the diameter, the surface to, um, I would say the surface to area to the
Mhm.
volume is the biggest with the pain pump because it are thinner, less myelinated, less, protected than heavy myelinated. So you just described what the anatomy actually has got throws us a bone there.
Yeah, and that's perfect. That's why pumps work so great.
Yeah.
They're like labor epidurals that are, practical that can go for 30, 40 days without needing a refill.
How do you
Yeah,
titrate?
this
But you have to titrate it, right?
Yeah, we first we do our trials are single day. We just put in a catheter because it's required by Medicare and inject bupivacaine and fentanyl. And
Mhm.
if somebody says I didn't get any relief, I'm thinking either you have central pain and or you're malingering because
May I ask a question? You put a epidural, no, you put an intrathecal catheter,
yep.
and then you start. Do you give a bolus, or this is a continuous? Is a continuous infusion?
We used to do a continuous infusion for a week outpatient, but it was impractical to
Yes.
fall apart and leak and all that. So then we started doing single shot through a catheter in the recovery room, and we
Okay.
rate pain before and after, and
So
then
bolus, you give bolus.
bolus. But you know what I've really determined in my practice? I would never do a trial unless it was required by insurance. I really know that a pump is going to work for a patient before I go in there. But anyway, it's required, so we do it.
Okay, yeah. And when you do a bolus, do you put a really catheter, or do you just put a spinal needle and type, 22 gauge and just give a bolus?
We,
How do you do that?
we could do a single shot with no catheter, but Medicare in their verbiage requires a catheter trial, at least they used to. So we put a catheter in. Plus, that gives us the ability to put a tiny dose in
reballs.
and then rebolus. And we sometimes they're
Got it,
there
got
for
it.
3 or 4 hours.
So you keep the patient in your PACU or whatever it is. You give them one bolus. Can you run me? Is it always fentanyl, or do you give other? Do you give fentanyl for the short acting part? Make us understand that how that process look like.
Yeah, we use fentanyl because it doesn't have a delayed respiratory depression effect. Morphine has a biphasic effect of
Mm.
initial respiratory depression, and then it floats up to the brain because it's water soluble, and then 6 to 12 hours later, it can have profound respiratory depression.
Mhm.
So fentanyl doesn't. It's like what you see is what you get when you put it in.
How much
And
you
then
put, like 100 microgram, 50 microgram, 20 microgram?
we might start 10 to 20 mics, maybe up to 50, like 2 doses of 25 mics, something like that. And many of these patients are super opioid tolerant when they're on, 100
Hmm.
milligrams a day of morphine or something.
Hmm.
So, but we have catheter location is important too. Some of our catheters are at C1, so there we might go 5 mics of fentanyl. And
Wow. So
and
that is how high you go.
yep, for
Where do you
face pain.
enter to get that high? I mean, this is not easy feeding it that far up. Do you go at thoracolumbar junction in, or how the far?
No, always at below L12. We want to be below the conus. So we try to probably 2-3 is our most common access.
Okay, and no problem to feed it that far up?
It's a problem, but we just poke it around and it gets up there.
Dave told me you just fiddle with it. I used to bring him in all the time, and
Yeah.
I found out he just, I don't know, you twist it, and I
And
watched him. You
so
can get it there
C1,
usually.
2, that is your preferred location for that C1, 2.
For unilateral face pain too, and we want it on the
Yes.
side of the pain. So it's got
Okay.
to be far right or far left because it's usually, facial right-sided pain or left-sided.
Okay. Now, is it like a stimulation that you can turn around and so on, fiddle it around, or
Yep, you can,
because
yeah.
for,
So
for
we
us
go,
surgeon, for us surgeon, we just shove it in and leave it a little up, and then we are done because we are not giving medication. We are just taking CSF away and so on. So and that is your goal, the high cervical area for pain management. Is that what I understand?
For facial pain.
yeah, for facial pain.
Facial pain. Oh, for what about the regular lower extremity and so on? Is it like mid-thoracic region that what you're in, what you prefer?
Whatever the level of worst pain is. So if it's thoracic pain, we'll put it at like T6. If it's lumbar, it's like T8, T7. If it's just foot pain, we might be at, T9 or 10.
Okay, I see. And
In
then,
many ways, like you think of stimulation.
yeah, I got it. Now, what about, you said that 10, if it's for the lower extremity, lower back pain. So you said you started 25 mic of fentanyl. And then, but do you always give as well like bupivacaine or lidocaine? No, I think lidocaine is not what used in the intrathecal space very often, right?
No, it's too much of a motor blocker.
Yeah. So, but you use bupivacaine mostly. How much do you put in?
For a trial. So I always use both drugs because that's what we're going to put with our initial infusion. Fentanyl bupivacaine is our standard infusion to start a pump. So I put in maybe 10 to 50 mics of fentanyl, and typically it would be 25 mics in a tolerant patient. And then I'll
Oh,
put 1 to 2 milligrams of bupivacaine in there.
okay, 1 to 2 milligram. Okay,
Yeah.
it's not the super high dose, but it is quite is not insignificant either. Okay,
Yeah. And if let's say they say no relief, and an hour later I might do another similar bolus, another
similar
25
bullets.
mics and
1 hour
one to
later.
two.
Got it. One or
Yeah,
two.
and then I'm testing them with an ice cube. So if I get a temperature block, I know I've got a block. And if they say my pain's no different, I'm thinking, what's going on here? So
Okay, I
because
see.
some patients want narcotics, they don't want a pump. And
Okay,
so we've had
so
some patients who are completely paralyzed and they still have pain. It's like, all right,
well,
go
those
somewhere
those
else.
might be those no, those might be like the thalamic
Central.
pain and so on, or higher level pain. Yeah. Now, so that's a very sweet test. That so you inject them 1 or 2, and then you check them with the ice cube and to see what the sensory look like,
Yeah,
and yeah, that temperature, right? That's very interesting. That use
yeah,
the temperature as your calibration tool.
yeah, because that's the first ones to go.
No, do you just fool them like cover it and just put the ice, or what is the, or do they see it, and how, no, how actually practically how exactly do you do that?
I just go to the refrigerator or freezer, get an ice cube, and I come back. Now I have these ice packs too, so I
Uh,
use those. And I
okay,
go, before I do the test, I go, okay, you can feel cold everywhere, right? So
okay,
then after the test, I go, tell me where it's cold, and if I start at the hip or something,
mhm,
and I'll go up the body,
okay.
and
So they
oh, it's
see
cold
it.
up
They
here.
see what you're doing. It's not like a blinded kind of thing. They see what you're doing. Got it. Got it.
Yeah.
Okay.
I don't
Now,
think they know what I'm doing. They're not really sure why I'm doing it, but
yeah, yeah. So, and then let's say they have what kind of positive response are you looking for? Like 50 again, or more or less?
yeah, just 50% pain relief, and then we're pretty much done. But once they say, yeah, I feel better, then we get them up out of bed and walk them around the clinic. And they have
Okay.
to do laps around our clinic. And
So you
most of
make
the
the
time,
sensor is blocked, but the motor still continues. And then I'm assuming at that point you adjust the dosage that you are going to envision for that.
yeah, we just want to make sure that, if they're completely unable to walk, then we've overshot. And then we let it wear off until they can walk. And we say, okay, you're walking now. Is your pain better? And they usually say, yeah, much
Mhm.
better.
Yeah. And
The one education point that I like to point out for these people who've gone through a stim trial and now are doing a pump, when we do a stimulator trial, we tell the patient that during that trial period, we're trying to get the program, the settings that will use in the actual implant.
Mhm.
And soon after the implant, we wait a week before we turn it on. But soon after that, we should be able to, cycle through settings and get their pain under control. But with a pain pump, I tell them it's a proof of concept in that we want to demonstrate that putting fentanyl, and this is more what you're talking about, the way this quote unquote surgeons do it, is that we want to show that if we put fentanyl and bupivacaine in there, they get 50% relief of some aspect of their pain. But in order to get optimal pain relief, it may take several months for us
I
to
see.
adjust the dosing. And there are lots of parameters we can change, including how fast medication is delivered. They can give themselves extra boluses. We can change medication combinations in the pump. But that takes a lot more time than it does just to reprogram electrons.
Okay.
So
Let's say
you
if
have to have a
they,
different mindset.
yeah, as you said, many of these patients are opioid tolerant. Now, and you use if you when you go to the permanent one and so on, you're not using fentanyl. Are you using fentanyl or using morphine, or what are you using?
Fentanyl
Start with the
bupivacaine.
same.
You still use the same. So
Yeah.
let's say what is the typical dose of it over 24 hours for fentanyl and bupivacaine?
I started 100 mics of fentanyl in 24 hours with 2 to 4 milligrams of bupivacaine in that same period. But then we give them boluses so they can. We have a 2-hour lockout. We say you can push this button every 2 hours and you'll get 20% of that dose.
Yeah,
So they can double or triple it.
Those pumps are really high tech. You can control it with a Bluetooth with your cell phone, right?
Yeah, we're just hoping that nobody's going to be hacking into them and start.
Yeah, and I think for me the value of the trial is for example, if you put in my rule of thumb is I look at the bolus for the trial and look if they had any, adverse side effects like respiratory depression, or they had some, hypotension from the bupivacaine. And then I'll double to quadruple the dose that they got for the trial and put that in a simple continuous dose for the first week, and then give them adequate oral pain medication that they can, cover their pain. And I tell them I don't expect the pump to cover all of their pain during that first week. It's more of a trial run. And then in subsequent visits that we have them come back quite frequently, initially, we escalate the dose as needed. And the reason to use fentanyl is still the same that we use it in the trial, is that the fentanyl is not biphasic like morphine is. So you won't have that secondary respiratory depression effect.
Now, do you observe them for a day or half a day after you implant it while this is running and so on? Or did you feel safe they can, after you implant it, put it on that 100 mic of fentanyl, 2 milligram of bupivacaine, and you're ready to go after the PAC-UF period is done? Or do they need to be observed closely?
No, we just send them home. We've already proven that they can tolerate it, with the trial. But we sometimes, if I'm nervous, I'll call them at like 7 p.m. or something just to make sure. But
the other safety check you showed me is that every patient, before they go home, I give them a bolus of medication that's at least equivalent to what they're going to get in the first hour from simple continuous.
I see.
And if in the recovery room they tolerate, a bolus equal to what they're going to get for an hour from simple continuous, then I can feel comfortable that they'll tolerate if they go home.
No, you said they can give themselves bolus. Is it like a PCA, right? Like there's a lock interval, there is a dose that you define. Is that correct? Is that the understanding correct?
Yep, exactly.
What is a typical bolus you allow them to have?
25 to Mike's fentanyl, maybe something like that. Maybe 20, 10.
Equivalent of 10 to 20 of 25 max of fentanyl. Got it.
Yeah. And by the way, these patients are taken off their oral opioids after the pump implant. So we taper those down and we say, instead of taking a pill, use a bolus in your pump. Because we want to get them off these drugs.
That's truly the best way to do it, I think.
I see. Now, how often do you see the overdosing or problem of that nature with a pump overall?
I don't think we've really seen an overdose of a pump. I mean, I don't remember one.
Okay, good.
Because they're pretty tolerant when we put them in.
Oh, safety profile is pretty good. Excellent.
Really?
Excellent.
It's really good.
Yeah. Now, there are some situations as well that you add additional medication, like spasmolytic medication and so on. Can you explain both of you to us a little? When do you consider doing that, and when you do that, what parameter are you looking for?
So we used to do baclofen pumps, but some of these baclofen folks need 500 to 1,000 mics of baclofen, and then if they withdraw, it could be fatal. So it's very dangerous for baclofen withdrawal. On the other hand, opiate withdrawal from a pump is like you just give them morphine, and it's not like an emergency.
I see. So you're not in a big favor of
I would not put baclofen in. I recently had a patient who we inherited from a practice in Texas that had a relatively low dose of baclofen. I think it was maybe 150 mics a day.
You don't mix it. Do you mix it if you're giving it? You do mix it, or you don't mix it with?
That pump had I think bupivacaine, baclofen, and hydromorphone in it. And we just inherited it,
Got
but
it.
there was some intermittent kinking with the catheter. And it was, so sometimes she just wasn't getting her medication, and she would go into the emergency room, and I was getting calls about her like having tremors, and even though it was a relatively low dose of baclofen, I think that it was more baclofen withdrawal. And I can treat, the opioid, but it's the baclofen is a much more challenging issue. So I'd prefer to stay away from it.
But I use baclofen in pumps up to 100 mics in 24 hours for spasms. Like if somebody has a lot of spasm in their
Yeah.
muscle, I think it works well at low dose, and it's not going to kill them if it stops, at that dose.
Yeah, this one was,
Um,
I think, about 200 mics a day. So, and we were trying to come down.
yeah, it
Yeah.
makes me nervous about that.
Now, any other medication that are routinely or rarely used in this pump, and if yes, for what reason?
Clonidine, but we stopped using that. Although I did have a patient who had super bad hypertension, so I put clonidine in there and it treated her hypertension.
Wow, wow. That is,
Cardiologists were very happy with me.
they were not. Oh,
No, they liked it.
they liked it. Okay.
Yeah, they
Well,
said.
now you just discovered a new venue for for pain pumps.
Yeah.
No, but no other, fancy medication that are routinely used. Like, I'm just thinking about that. They use often multimodal kind of for
Well,
oral.
for cancer, we'll put in ketamine.
Yep.
Oh,
But
Yeah, we put in a fair
Dave can
amount of
talk more
ketamine.
about that.
yeah. Ketamine is, what I noticed. You may have seen our multimodal pain management for our patient. And and there are lots of patients, they have a huge emotional response to the pain. And we have discovered, this patient, you give them enough medication, they're sleepy, their respiration rate goes down, and so on. But as soon as they wake up, they're back to horrible pain.
Mhm.
And then we give them like the dose of ketamine. They're like perfect. They're like awake, happy, and then ketamine has a short lifetime, and then it goes down, and then they're back to that, and then we put them on a. So there have been a handful of patients that we have put on a infusion over the night and so on. It really makes the management for a certain group of patients with the pain in my practice who have a
You're talking about post-operative?
post-operative. Yes, yes,
Okay, yeah, that's interesting.
yeah,
Yeah,
yeah.
we love ketamine. It's just great. I mean, it's safe. You can't really hurt someone with it.
Yeah, how in the pain pump? You're talking about the pain pump, right?
Well, no, we use it for IV sedation too
Oh,
sometimes,
okay. I see. I see.
and for surgeries,
The,
and
Yeah.
for the pain pump, the struggle is that there is some animal data that shows that ketamine is neurotoxic.
Mm,
So we usually reserve it for patients who have cancer and maybe have a shorter lifespan. But
exactly.
then in our case review, we've had some patients who the pump was initially implanted for cancer, but were really good at curing cancer or stabilizing it. And they've, had ketamine maybe in their pumps. Don't you remember one that had it for 2 years or something?
Yeah, we
And,
looked at our
and it just,
data.
they seem fine.
We have about 5 or 10 that survived cancer and had ketamine, and it didn't seem like they had any problems. We didn't have enough to really do a study on it.
yeah.
Yeah.
Well, I'm going to show you our ketamine that we are giving. I'm going to share it so everybody can have a look, and feel free to get the screenshot of it. Are you able to see our so-called perioperative pain management? Are you guys
Yeah.
able to see that? Now,
Oh,
again, it's very deliberate, and one of the different is what we do. We don't go literally burn all the muscle. In a regular spine surgery,
Mhm.
you burn the muscle, you burn the periosteum, which is very painful. And some people even use the so-called aquamantis. It's a device that uses 120 volt DC electricity. Literally, you see muscle becoming like a medium or well done, not medium, but well done steak while you're using it. So we kill the tissue, and as we all know, that tissue have no pain. If you burn the periosteum, which is very pain sensitive, they wake up initially not as painful, But obviously the pain starts when the whole inflammatory reaction starts. They are months in pain. They literally are in horrible shape, high risk of infection and so on. We don't do all of that. We just poke through the muscle and we create grade 1 burn. These patients still go home next day, but the initial phase after the surgery, if you are not prepared, can be extremely painful. That's why we have our so-called perioperative pain management that obviously start in the surgery and so on. But I'm just going to go down and show you that we have found that small doses of ketamine here. I'm not sure if you guys are able to see that. Let me make it clear a little.
Yeah, we can see it. We can see it.
Small dose of ketamine in a group of patients that you think you have done enough other things really makes a huge difference. And as well, it starts as well in the post-operative. You see, it looked like a very complex pain management system, but we have been able to show by following this patient, we do a 3-level fusion on somebody who had 5 years, 10 years of pain. We are able to send them home not after injection or a small procedure, but after a 3-level fusion, we are able to send them home within 2 to 4 hours. And in the post-operative, we will consider, small doses of ketamine. And even, I'm not sure if you guys have tried this magnesium sulfate. So
our CRNAs do often, especially for my for the SI joint fusions that I do.
Yeah.
They use magnesium.
So
no, is that an oral, like a solution that they drink?
Well,
IV.
These
IV.
are IV. These are IV in the PACU.
Okay.
And again,
and IV Tylenol as well.
Yeah, IV Tylenol or Tordol, and I think Tordol is extremely effective. And the way we do the surgery, I'm really not concerned about the perioperative bleeding and so on. Sunny, I'm not sure. Sunny, do you use as well regularly Tordol for your patient? Oh, I'm not sure if Sunny's with us or not anymore. So, but yeah, ketamine has been really. So, if anybody is interested, let me know. I'm happy to send you this protocol. So
I'd like to see that. I think that looks awesome.
yeah,
I mean,
but
exactly what I would do.
It's numbered, it's algorithmically. You do this, then you do that, and so on, and it sort of gives us a good understanding. Sunny, I was asking, you just went off. Do you regularly use Tordol on your post-operative cases, fusion cases?
No, just on and off.
Okay, so now I have been, I used to use it on and off, but I have no. Now I'm using it regularly on all my patients. And it's like IV Tylenol. I think they have a similar effect. And
But Tordal's anti-inflammatory, and I bet Sonny is worried about bleeding when he does the bigger surgeries.
yeah.
Oh, no, I'm not worried about bleeding. I'm just worried about interference with the fusion. If you more than
Yeah,
48
that's the other
hours,
thing.
yeah.
That's the other thing I hear periodically.
Yeah, I'm not concerned about bleeding with Tordal.
Yeah,
Okay.
I think there are some studies that they show this the medication they have effect on fusion. There are some other studies that have said there's absolutely no effect on it and so on. But I think it's mostly if you do a regular surgery, you're reducing the perfusion of the bone. And I think with the way we do this surgery, we are not really cutting the muscle. We are not stripping the muscle of the bone. And if the vascularization of the bone is through surrounding muscle. There's not an artery of L4. It's just a surrounding muscle that gives it perfusion. So I'm really not concerned about the Tordal in that regard at all in my group of patients.
Oh,
Now,
good.
having said that, let's come back. Actually, I want to get more your view on this. So if you put ketamine, how much ketamine would you put in your pain pumps and for what purpose?
So for cancer pain, if it's terminal, we'll put in 100 to 200 mics in 24 hours. But we've had some people up at 1,000, 1,500 mics of ketamine, at the end of cancer pain, and they tolerate it pretty well.
Yeah. And now, actually, now that you're talking about that, I mean, you and I, we talked about that previously, privately, and in some other meetings and so on, but the post-cancer pain management is a big deal. You know, these are patients that are, some of them are absolutely miserable. They are like, and they're doing, helping them to go through that hospice phase and so on is a truly one of the best things you can do for them and the family, obviously. Does your cancer management, is it all the same, or things change, or are you more liberal with the dosing and so on? Can you educate how, when you do that? And number one, what percentage of your pain pumps are for cancer patient? And as well, what do you think? What percentage of legitimate cancer pain patient that would benefit from that are actually getting it? What do you think?
So when we think about cancer, if it's a terminal situation, we just pull out all the stops. We say you take whatever meds will help you, and we put in a pump. We'll be really liberal with the dosing, and most of these people are very tolerant. So safety isn't usually an issue. We just ramp it way up. And we use ketamine. There's multiple forms of ketamine in the pump versus nasal applications and IV, whatever. But yeah, we're super liberal with cancer pain.
Well, tell them about how we would take patients who are hospitalized and do the epidural catheter and send them home.
Yeah, that's another thing is like a labor epidural will stop labor pain. An epidural in any part of the spine will stop segmental cancer pain. So I used to put them in cervical for people with like Pancoast tumors, and they'd be outpatient. But it's logistically very difficult because you have to have a fanny pack with a bag of fluid and a pump, and it's an external thing, so it works, but it's hard. The other thing is we have to fight with hospice because hospice doesn't want any fancy stuff. They want cheap. They want methadone,
Easy.
basically.
Yeah.
And we're okay with that. But if we put a pump in beforehand, then we can use it in hospice. But they won't let us implant a pump once the hospice gets in there.
Okay.
But David developed some relationships with oncologists, and they would call us, and patient was only in the hospital for pain, and they would discharge him directly to our clinic, and we would kind of kill two birds with one stone. You don't have to do an intrathecal trial. You can do an epidural trial. So we would place an epidural catheter, and then in some patients who we trusted, we couldn't put in a pump immediately. We have to do a trial first, technically, but we would send them home with boluses of bupivacaine that they could give themselves, administer for not a long time, but maybe 3 or 4 days, so we can get them on the schedule, so they could just not be in the hospital.
We did that. I remember that. That's kind of like cowboy stuff.
How many?
No, but I was surprised by it. But I mean, patients are so grateful.
Yeah, it really works.
They're the best patients because they're so grateful to have something, and they don't get tired, and they can have some relief until we can get a pump implanted.
And do you? How many of that? Just for me understanding, how many of that do you do a year for cancer patient of these pumps?
We used to have Jade Anderson was our oncology doc who sent us all his patients, and then a couple other guys. But most oncologists do not want pain docs involved. They want to do systemic drugs. Yeah. They kind of make the patient
comatose. It's underutilized. This is totally underutilized.
I think so.
Yeah, this is hopefully when I put this out there, we raise awareness and so on. Hopefully that we can change that, because these patients obviously are miserable
so earlier in my career, when I was working in hospital systems, I would get the call when the patient was like the last week of life or something like that. And often at that point they're too ill to implant a pump. And so
that's too late. I think 6 months to a year is a good time frame, to utilize that. And these pumps need to be refilled every 4 to 6 weeks, right?
Could be up to 2 months, depending on what's in it.
So that means, I mean, knowing how this hospice thing go and so on, that all the medication you have there, instead of that, you just get a cell phone that you can give yourself bolus and so on. I think it's totally underutilized.
And I mean, I feel like so again, not many patients, but again, back when I had these patients, when I wasn't with Nura and I didn't have as much experience and support for pumps. I remember one patient in particular, the neurosurgeon I was working with wouldn't support me doing an external intrathecal, but an external epidural catheter. So I placed that and I would go and round on her like daily. And you just couldn't get the density of, I got to the point where the solution was too concentrated to give any more bupivacaine. And so we eventually had to go to just IV medications. And I believe the patient, if they'd had an intrathecal pump, would have lived longer, because when they become so sedated, they can't eat. So she really died. I mean, it was cancer, but she died of starvation because, of course, it wasn't feasible to put in a feeding tube for somebody who was so sedated for pain that they couldn't survive. So the pumps, I think, can really maybe
Give
not
quality,
cure, but
I think, yeah,
prolong, have a longer quality of life.
No, it's not about just prolonging life itself. It's about giving the patient and the family quality life, not somebody who's practically mentally is checked out already, but the heart's still beating. And
ultimately, I mean, this patient, this is what I observed. She just basically starved to death.
Yeah. I see.
Because you couldn't feed her. She could never be awake enough to eat or drink. And I mean, hospice sees that all the time, but it wasn't something I was familiar with.
Yeah, so that's the sad part of our practice, but it's necessary. Well, I'm going to hopefully, when I put it out, I emphasize on that for that cancer treatment. Hopefully, we can raise some awareness about that, and maybe in one of our future meeting, David or Scott, come and talk about this thing in one of our Avicenna Society meeting and raise some awareness about that, specifically about.
Yeah, we'd love to spread the word. And we've published 2 pretty important articles in the past since 2020 and 2022. We published our own experience, and we have 1,000 patients with pumps right now that we manage. We did a survey of 24 questions, like, what do you think of your pump? Does it help you? Are you on less drugs? Are you going to the ER less? What's your quality of life? All this stuff. And the satisfaction was just through the top. And people
Could you
said,
send me
I love
those
this
papers?
thing.
Could you please send me those papers? I will put it across our society. I think that would be very helpful thing for us, for a surgeon to see that these methods that are really effective.
Yeah, I'll send them to you.
Yes, please. I would appreciate that. Now, one last question. I wanted to talk only 20 minutes, but this is so exciting. We got this session is just dedicated to your work. One last thing that I wish Dr. Samadani was with us, because she does this spinal cord stimulation device for spinal cord injuries. And she is actually, I think, world famous even for that. And she reports that in certain group of people, they get actual function back from the stimulation device, which is for us neurosurgeon, we think when the function is lost for good, and so on. Do you have, David and Scott, do you guys have any experience for pain stimulation device for spinal cord injury?
Yeah, so we work with Dr. Samadani, and we do her trials for her paddle lead implants. And her feeling is that even in a spinal cord transection, some of the fibers below the lesion are still viable. And if you can send electricity there, you can get some bladder and bowel improvement and maybe even motor improvement. So it's pretty dramatic. It's pretty amazing.
And in talking with her and patients, it's often, I think we think of being able to walk would be the greatest thing for these patients, but in reality, what they really value is the ability to control their bladder and their bowels, so that they can toilet themselves.
Results there.
Yes,
excellent.
We have to do. It is pretty amazing work.
Yeah, can you explain? That do you put the electrodes above the level? Obviously, I'm assuming above the level of the injury. You run me a little through the process, and in your first-hand observation about what you have seen there. Do you mind, both of you, tell me your experience with that?
Well, early on, I was thinking you can't really help a spinal cord injury patient with a electrode below the transection because there's no viable cord. But she's saying, yes, there is some viable cord below the lesion.
Oh,
So
so
she goes,
you put it below it.
isn't that right, Scott? I mean, our
Well,
trials
so
are,
this is, yeah, so this is, so this is, I think, the trial versus the implant. She seems very concerned about the scar tissue formation from a stimulator trial. And so kind of, in some ways, the way we think about a pain pump doing a trial is just like an insurance requirement that we do. And we think that it will work anyway. I think her attitude is that we have to do a trial in order to get an implant. And often she uses the diagnosis of CRPS, though the real treatment is mobility. And so she's told me that she wants me to put the leads below where she would put a paddle lead because she doesn't want any more scar tissue to form. So I think she will often put the paddle lead where the transection is. But when we do the trial, we go above or below that. And again, the issue is this, that's what she's explained to me. Do you remember discussions like that?
Yeah.
yeah. And that's the challenge for her is to try to get a lead where there's a spinal cord injury. I mean, sometimes the anatomy is all messed up.
So trial at the level of the injury, but
Below, but below where you would place the paddle is what she's told me.
yeah.
I mean,
Yeah.
really, in other words, the trial is, during the trial, she's not expecting fantastic results immediately in a 7-day trial period, but she uses a diagnosis of CRPS and the patient reporting pain relief for CRPS to get the authorization to place the paddle lead, which can help with pain, but her primary intention is to help with mobility. And I think that happens more long-term than just, they're like able to move in the trial, then you take out the lead and they can't, kind of like we do with pain. It's more of a long-term process, I believe.
Okay.
Yeah, she wouldn't do a trial if she didn't have to.
Okay.
Yes.
And trial as well is 7 days or something, the same kind of trial, or is it a different kind of trial?
Well, the trial length, unless I haven't reviewed the LCD recently, but Medicare doesn't really mandate a trial length, but it seems like if you do a lot of trials that are really short, like only 3 days, that gets you on their bad boy radar. So typically we think of 7 days is kind of what you should be doing regularly.
What do you mean bad boy radar? What is that?
Well, I think in some patients, you will know within 3 days whether or not the stimulator is going to work. But I think that at Medicare was viewing some physicians who did really short trials as just not giving it enough time or giving enough evidence to proceed with a expensive implant.
I see.
That was a discussion I had a long time ago with some vendors.
Most of people in the United States, they have 4 days trial, something like that, to my best knowledge.
That's all required.
And then there's other reasons to have a shortened trial. For example, if they're on anticoagulant medications and can't hold it for a long time, something like that.
Do you think the risk of infection is any different from, let's say, 3 days, 4 days, or 7 days? What do you think?
I don't remember seeing any infections from our trials. Do you, Scott?
Okay, so there's no reason not to do
trials.
7 days. In your opinion, there is no reason not to do a 7-day trial.
And in Europe, we're always told, I mean, I always heard this, and I don't know if I verified it, but in Europe, sometimes they would do as long as 21.
Really? Well, I would be.
I mean, you'd
nervous.
observe it, you'd still check it, but.
Well, as a neurosurgeon, I would be extremely nervous. Something going out of the skin, going to the spinal canal for 20 days, and those people are. Sometimes we do that. This, lumbar, catheter and so on. Okay, it's a catheter, not an electrode. But that makes us extremely nervous, and the rate of infection is not trivial. But again, these are sick people in the ICU. It's a different set, and so on. But yeah,
I mean, honestly, the scar tissue is really much more of a risk factor than I'd ever appreciated. I mean, I had a patient who I did 2 stim trials at the same level, and when I went to the implant, there was so much scar tissue, they got spinal cord injury. Went from mild stenosis to severe stenosis with just, I mean, it was aberration to have 2 stim trials.
Yeah.
Yes.
So I think previously we talked about that implanting the permanent one and then tunneling it, making it cross, making extension and so on and so forth. But
Mhm.
people don't do that anymore. Why do you think? Is it a coding thing or payment thing, or why don't people do that anymore? Because when I was in the residency 20 years ago, more
Mhm.
people would do that. Put a
Yes.
final electrode, tunnel it somewhere,
Mhm.
the extension, then get the extension out of the skin, and then they would go back and put the
Yeah.
implant. But
Again, that's how I originally learned these.
yeah,
But
but why
Dave's probably
don't
has a little bit broader
yeah, why do you
perspective
think
as
people
to
don't
why.
do that anymore?
I stopped doing it because when I opened up the midline incision where the
It's
anchors
all
were and the
icky.
extensions, it just looked crummy, and I think
Yes.
we had a little bit statistically higher infection rate. So, and then there might be an economic issue with it too. I don't know if you get paid separately, if you do a separate trial and a separate implant.
Well, we no, the answer that I got when I was doing this when I first started in Montana with that spine surgeon, the reps loved doing it this way, burying the leads, because almost every single patient who did the trial went for the implant, and the stimulator companies really, their economic, it's the batteries. That's what they make money on. But I was much more conservative and selective with who I would offer it to, because it's, and they were also, the patients, they're a little bit more committed, right? Because if you bury the leads, if it doesn't work, in order to remove the leads, you have to again go in surgically and remove them. But also you don't get paid to place the lead the second time like you would with just a percutaneous.
Okay.
So when I joined Nura, and Dave pointed out that if you do it just percutaneous and anchor the leads outside the body, it is truly like it's just like an injection in most
Yeah, it
ways.
is. It is. It's not a real
The
surgery. It's an
the
injection.
downside is if you really struggle to place the leads, then you're probably going to struggle again when you're placing them permanently.
Yeah.
But you also get some insight as to maybe, the level doesn't work, and you just take notes about that. So when you go into the implant,
Yeah.
it goes a little bit quicker.
So is the payment from Medicare any different if you do it one way or another?
I don't really know. I have to check on that.
Yeah.
The struggle I had when I was doing it that way was that since most people are doing these percutaneous trials with the leads, not burying them, if I buried the leads, I still wanted to implant within a week if they got relief. And it was a struggle to convince the insurance companies sometimes to pay for a battery placement within, so I would have to know within 3 or 4 days whether it was going to work,
I
so I could
see.
start prior authorization to get the battery placed.
I think you answered the question, because if it works and you want to do it that way, it has to be done within 1 week, maximum 10 days or so,
Yes,
two
yeah.
weeks.
So
And
that
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 would,
was that was a that was a struggle. So in the practice I was in, that was an established thing, so they'd
yeah.
figured out how to do it. But when I went to different practices and that wasn't the norm, that was the reason they said, it's just too hard to do it that way.
Well, this
But
has,
for something like a DRG system, which times the leads are really hard to place, it would be sometimes really nice.
yeah. Well, I think even if you don't put this is as a neurosurgeon, I would say even if you don't put the battery in within 1 to 2 weeks, at least you have to go get that piece of connection out. So there is no
Yes.
connection to outside
To
world.
the outside, yeah.
Yeah, I think that is sort of adds some complexity. I think probably this is the reason why we are not doing that anymore. Insurances and getting that logistic part of it approved. I guess that might be one answer. Well, I learned a lot today, actually. Thank you, guys. That has been really very educational for myself. And David, I would love to literally get your papers, and I'm going to use the system here to make a write-up of our conversation today and put it out for our society. I send it to you, and if you have any changes you want me make to that write-up, and please feel free to not just look over. Please look over what I'm going to put the write-up from this conversation. But I definitely want to emphasize that how underutilized the pain pumps are for not only chronic pain but cancer, specifically palliative cancer patient.
Sounds good. I'll
what you
send you
should
the
really,
articles right now.
Say one more
yeah,
time.
you should. I, well, I was going to say what you should really ask Dave about is how to build a pharmacy,
Oh, yeah.
compounding pharmacy.
Well, that is
That's the nut that's hard to crack,
oh yeah. Well,
or else everybody would do pain pumps.
well, we don't want to disclose too much of David's proprietary kind of information. Some secrets have to be kept. But hey, Scott, you are there. You learned that, and because David, I like you to live for 500 years, but our knowledge has to survive us. That is what it is. So, Scott, you're in the right place to take that knowledge to the next step. Well, guys, it has been extremely educational for me. Thank you so much. Okay.
Well, thanks.
And
Thanks,
will you
Evan.
will you send that the intra-op pain
I will.
management?
I
Because I
will.
think that could help with my SI joint fusions.
Absolutely. Well, certainly. It's actually I think the first even half of each segment would help you with sacroiliac joint because they are less painful
Yes,
than a
but
three-level
this,
fusion where you put 17 pieces of metal in. So that is what I do.
but in my practice, the
Yeah,
SI joint fusion is the most painful
absolutely.
post-operatively. So
Yes, yes.
we do. I think we do a pretty good job. But anything that would help would be.
I will send it to you, to both of you right away. Okay.
Thank you very
Okay.
much.
Thank you guys. Bye bye.
Okay,
Bye.
bye.
Thanks.